everyone, and welcome. My name is Deb Cunningham, and I lead strategic partnerships for Aspen Ideas Health and other programs here at the Aspen Institute. And on behalf of our entire health team, we're delighted to have you all here with us today. COVID has kept us from gathering in person for quite a while now, and we've worked hard through the wonders of Zoom to keep conversations like this one, inspiring and informative conversations, in front of all of us. And again, we welcome you here today. But do mark your calendars, because we are well underway with plans for our in-person return to Aspen next summer. So Aspen Ideas Health 2022, Aspen, Colorado, June 22nd through the 25th. Mark your calendars, and we hope to see you there. But for now, back to today's important discussion about the future of screenings for cancer and the impact that promising technologies will have on public health. We know that finding cancer early saves lives, yet still too many eligible adults don't get screened as recommended. Why? What's behind this gap, and how can innovations such as easier and more accessible screening tools help more patients get the care they need when they need it? Here to share their thinking and some hope are AmirAli Talasaz, Anjee Davis, and Dr. John Torres. A bit more background on each, and then we'll get right into the discussion. AmirAli Talasaz currently serves as co-founder and co-CEO of Guardant Health, a leading precision oncology company, and our partner for this event. AmirAli is an entrepreneur in the rare genomics and clinical diagnostics fields. Prior to co-founding Guardant Health, he was Senior Director of Diagnostics Research at Illumina and led the efforts for emerging clinical applications of next-generation genomic analysis. Before Illumina, he founded Orifex Biosciences, which focused on purification and genetic analysis of circulating tumor cells for cancer management. During his academic years, he led the technology development group at Stanford Genome Technology Center and received his PhD in electrical engineering and master's in management science from Stanford. Anjee Davis joined Fight Colorectal Cancer, Fight CRC, in 2011 as the first director of community engagement. In 2015, she accepted the role of president, growing Fight CRC 30% year over year between 2011 and 2019. With nearly 2 decades of experience in patient and research advocacy, Anjee fights tirelessly for patients' access to care and research advancements. She created the award-winning 1 Million Strong awareness campaign and accelerated research by convening international researchers to tackle topics like early age onset colorectal cancer and immunotherapy. Under Anjee's leadership, Fight CRC has gained influence on Capitol Hill, resulting in increased funding for medical research, passage of key legislation, and the formation of an important congressional advisory committee. Dr. John Torres, or Dr. John as we know him around Aspen, is NBC News' senior medical correspondent and an emergency room physician. His reporting covers a wide range of health-related issues all across NBC's broadcast, cable, digital platforms. A U.S. Air Force veteran who completed a tour of duty in Iraq in 2004, Dr. John has contributed to rescue efforts out of the South Pole and in the wake of Hurricanes Katrina and Rita. Throughout his career, he has made numerous humanitarian trips to Central and South America, providing medical care to children in need. Utilizing his combined medical and military experience, Dr. John teaches NATO Special Forces. Dr. John, we thank you for your ongoing collaboration and your always expert moderation. The virtual stage is yours.
Great, thank you very much, and glad to be here. Very excited about what we're going to talk about today, because I'm always looking towards the future and what kind of things we have. I'm a sci-fi geek, so every time I think about the future, I think about the tricorders they used on Star Trek, where they could diagnose everything in about 10 seconds. We're not there yet. This is a ceiling fan remote, so it's not going to do anything other than cool me off a little bit. But we have 2 experts here that are going to help us understand where we're going, where we need to go, and what we need to do to get to those areas. And first, AmirAli, I just want you to introduce yourself and give us a brief introduction.
Yeah, I'm AmirAli Talasaz. Super excited to be here. Thanks for having me, and looking forward to a great conversation. So, just as introduction to Guardant Health and what we do, at Guardant we are focused on liquid biopsy, blood test for cancer management. We have tests in advanced cancer stage that tells the physician what kind of treatment is going to work for the patients. We have the test that tells if those treatments are working for the patients. And also we have tests that shows if the cancer is coming back in cancer survivors. But what we are really thrilled to talk about today, and it's going to be the focus of conversation today, is a test that we have developed for early colon cancer screening using just blood tests in average risk patients, many individuals in this room, which we are very excited about. And why it's important is, with all the progress that we made in cancer screening, colon cancer screening, still the rate of compliance of people to colon cancer screening is remaining at 66%. And during last decade, really the compliance rate has not changed much. And there are many issues that goes into that lack of compliance. And we really believe and hoping that this blood-based cancer screening can contribute significantly in closing the compliance gap and really taking this screening test to patient side instead of bringing patient to the healthcare systems and healthcare, and which is generating some of this lack of compliance issues in this space.
Great, thank you very much. And Anjee, if you could introduce yourself.
Sure, I'm really excited to be a part of this conversation. I am honored to be a part of Fight Colorectal Cancer, where we're a national advocacy organization and represent over 1 million colorectal cancer survivors in the US. We focus on pushing and changing policy to increase screening for colorectal cancer, access to treatment and care for colorectal cancer, educating patients on the best treatment options and screening options, as well as pushing researchers to advance the science, to advance screening options, to advance treatment options. So really excited to be a part of this conversation and appreciate having an advocacy voice as a part of it.
No, this is fantastic. And thank you both. And thank you both for giving us your time and being here with your expertise. AmirAli, let me start with you, because I think when most people think of cancer screenings, colon cancer screening tends to be one of the ones they think about, and the colonoscopy tends to be the majority of what people think about. But where are we right now with various screenings, especially for colon cancer?
Yeah, so there are different modalities out there, which has basically FDA approval and endorsement by different guideline committees. The gold standard, as you mentioned, is colonoscopy, but there are some other tests, and some of the main ones are stool-based tests, FOBTs, and then FIT tests, and then finally FIT plus DNA test, and some of the tests called Cologuard, which is broadly used in this space at this time. So when we look at all these kind of test options for physician throughout the years, as I mentioned earlier, still we are seeing the compliance gap is very wide. When you look at the compliance about 10 years ago, it was around 62-63% of the people were complying with any kind of screening methodology. And now still with all these options, still the compliance is stubbornly at 66-67%. So, and when you look at actually underserved communities, you're going to see some of this disparity and lack of compliance more severely. About just 59% of Hispanics are complying to any kind of colon cancer screening, and African Americans are also at around 55%. So, and when you look at the root causes, you can understand maybe why we have this compliance issue. For colonoscopy, there is, some prep and then the day of procedure. And for some people, some recovery post-procedure, and the productivity loss, number of days that the patient needs to commit. For other stool-based tests, they are mainly the same in terms of significant patient follow-through that needs to happen, and that reduce some pressure to the compliance of this life-saving screening methodologies.
And Anjee, one of the things that frequently gets talked about is for these screening tests, it's the amount of prep work and the amount of time that patients have to put into it. It's going to decrease the amount of people that actually do this. Is that why patients aren't going in and getting these tests, or is there other factors there as well?
I think it's a complex issue. One of the unique things about colorectal cancer is the stigma associated with it. Not a lot of people like to talk about poop or their bowel movements. And so unfortunately, when you talk about colorectal cancer, it just kind of comes with it. You have to be comfortable. A lot of times people don't like to share with their physician how regular they are, or if they have blood in their stool. And I think as it relates to colorectal cancer and screening, it's a couple things. What we've seen as it relates to market research, looking at African Americans specifically, it's stigma, not wanting to go and talk to their doctor about having a colonoscopy and where that colonoscopy is going to go. I will say that non-invasive screening has helped. It's an option. It's a less expensive option. But what's really important to consider is, as we come up with innovations like the blood-based test and non-invasive screening test, is that we include a very wider definition of screening to include a follow-up colonoscopy if it's positive. But I do think that colorectal cancer is uniquely challenging because it's hard to talk about.
And will these blood tests we're talking about, these liquid biopsies, these kind of what, we always talk about holy grails in medicine, and this is certainly one of the holy grails of having something simple like this that can detect something with what we call that sensitivity and that specificity. Will that ease the backlog of what's happening right now with the colorectal cancer screenings or cancer screenings in general? And,
if that's directed to me, sorry.
No, go ahead, Anjee.
I think 100%. I mean, we saw programs like the Fit Flu Test program come out. When you can integrate a test like a blood test into your normal care, where patients are used to getting their blood, taken, they're going to see their primary care physician, they'll have their blood taken. It's much easier. It's not like having to go home and collect a stool sample or send it in, or whatever stigma you have around, poop is not a factor. You're not having to take a day off work. You're not having to have someone drive you to the clinic. There's a lot of things that would simplify the process for a patient. And I'm not going to hold industry to this, but you're going to draw down costs, hopefully, for patients with that initial screening. So I think it is the holy grail of being able to screen large populations of individuals for colorectal cancer.
Go ahead.
Yeah, completely in agreement. When you look at logistical advantage of the blood draw, how simple that would be, how integratable that is to the current practices. Like the physician makes a decision to screen somebody, consult with the patient, give that option. Patient can get the blood draw same day in the same clinic, same floor, or the same building, or get it from a local blood draw center, or get the mobile phlebotomy in the patient's home if the patient is open to it. The logistical advantage of this test versus really significant follow through that the patient needs to go through with other kind of screening modality gives a lot of hope to all of us in the field that blood-based screening can play a significant role to improve this access and reduce this compliance gap.
Now, we talked about the colorectal cancer screening rates in particular, but cancer screening rates across the country, across the world have dropped because of the pandemic. Has that been a significant drop, and do you expect that to pick back up? Because I know one of the things here in Colorado where I live, the hospitals right now are being overwhelmed, but it's only about 12% of COVID cases. The rest of them are backlogs from people who either waited and have situations now that require surgeries or are now getting those screening tests. Is that something you think will pick up fairly quickly, AmirAli?
So when you look at actually the post-pandemic, some of this compliance issue actually has become even more problematic. The reality of colon cancer screening is during the first 4 months of pandemic, the rate of screening dropped by 94% in the United States. So we had huge issue with compliance, and pandemic reduced it almost to zero. And even since then, still the rate of screening has not come back to the normal. So we are dealing with the backlog of the people who haven't been screened. And many people in the field are forecasting that actually the rate of advanced cancer diagnosis is going to go higher just because cancer is continuing to be developed in people's bodies. So we are not just detecting them at the time that we can do some more effective interventions. And when you look at even, again, the health disparity, actually, this drop of compliance post-pandemic was worse even in underserved communities in some of the locations. Again, some of it because of access to the healthcare system and the barrier that basically those individuals have during pandemic to get access to care. Really, one of the promises of blood-based screening is instead of bringing patient always to the healthcare, we are bringing healthcare to the patient side. It has that potential. So that's why we are very bullish about the potential of contribution of blood-based screening in the field.
And Anjee, looking forward here, one thing the pandemic has taught us is that, prior to the pandemic, we talked a lot about disparities in healthcare. The pandemic brought that to the forefront, and we now realize that disparities are there. They're almost ingrained in the system at this point, and breaking through that's difficult. Where do we need to go with cancer screenings to break through that? Because we found out with vaccinations, you have to get to the communities, you have to get to the community leaders, and that's important. How about with cancer screenings?
I think the same. I think with blood-based screening tests and innovation around screening, I think it's really important. And I just want to kind of go back a little bit to what COVID has done is that with that drop in screening rates, there is a backlog of patients for sure. But, being able to ultimately use telehealth in a different way and be able to counsel a patient to screening will be great, but you can't necessarily do that with a colonoscopy in the same way you could with a blood-based screening test or a non-invasive screening test. So I do think that being able to navigate patients in rural communities, patients who may not have access to a gastroenterologist or specialists readily, who have a backlog. I mean, I think this is the future of being able to integrate multiple modalities based on what a community needs, but also I think it's highest and best use of resources. So being able to say, you are a low risk patient, you have no family history, you have no signs and symptoms, you can have a blood-based screening test, you can have a non-invasive screening test, and you better utilize the specialist resources to have a colonoscopy ready when they need one, or if they have a positive blood-based test or a non-invasive screening test, they're able to better utilize resources in local communities. Because I will say where I'm at right now, the backlog could be as long as 3 months. And the reports right now are saying not only is there a significant backlog, but the death rate for cancer patients is increasing by 10% because of the backlog. So I think we're pushed to have this conversation because we have to use our resources more wisely, and we have to accelerate opportunities safely for patients when the technology is there.
You talk about this 3-month backlog. I know we all tend to have a lot of resources that we can use to help us get to the doctor's appointment, get those appointments, make sure we keep those. But even with that, 3 months from now, it's very hard to keep an appointment 3 months from now, even having resources. I can imagine in the communities where they don't, in the families where they don't, this could be even tougher.
Most definitely. I mean, and think about it for someone who is an hourly employee who can't necessarily schedule 3 months in advance because they don't have their work schedule laid out, or they may not have, appropriate support in their life to be able to schedule travel, prep, insurance coverage, making sure they have all the things ready in 3 months, and then having to cancel maybe because of another issue due to employment or childcare. So, I mean, it really hits home for patients who I think are underserved or medically underserved when there is a backlog, when there are challenges, and there are a lot of barriers to care as it relates to this.
And AmirAli, one of the things that I want to make sure we focus on before we don't have any more time to focus, we could talk for 4 hours on this subject, but the question I think most people have is we talk about these liquid biopsies, we talk about these blood tests to help detect cancer early on as screening tests. When are we going to see those?
So actually,
I want you to get your crystal ball out.
Yeah, it's around the corner. So there are, we talked about our blood test for colon cancer screening as the lab developed test is going to be launched in the first half of 2022. And we are expecting if, our pivotal clinical study that we are finishing, it goes well and successful FDA readout to have the FDA approval and launch of the FDA approved version in 2023. So really it's around the corner, and we are expecting a much brighter future is going to be generated for the patient and the whole, health of our communities. Having said that, there are still some kind of barriers to really give access of such innovative tests to broad patient population in the United States. We are very pleased with the progress that FDA agency is making to help these innovative devices to go through review cycle and the guidance during the busy schedule that they have caused by pandemic. We are very pleased with cooperation of payers, mainly CMS for, that they set coverage policies. In fact, before any tests get qualified, they have a finalized national coverage determination for blood-based cancer screening that meets some, certain minimum criterias. So, and this is, I'm not aware that they've done this in our space before, that before anybody qualifies, there is a coverage policy for it. Having said that, there are some other barriers in the field. And one thing I would like to name is, after ACA, there's been a lot of actually responsibility and authority given to US Preventive Services Task Force, or USPSTF. And the intention was good, that USPSTF tried to actually endorse some of these screening tests. And as a result of this, all patients in the United States can get access to this, health-changing offerings. But the reality is they are so underfunded that they can review this innovative test every 8 years. I repeat, every 8 years. And, some of it is related to really the lack of funding that they have. The scope of work for them is pretty large. They are looking into all screening tests, preventive medication, healthy behaviors, and the amount of funding for them is so low that they can really review and update their guidelines typically every 8 years. And when you compare this to other guideline setting committees like ACS, NCCNs, typically like when you have a brand new therapeutics or intervention or diagnostics that could be life-saving, they update guidelines pretty quickly. But the reality of patient access in the US would be kind of limited with this 8-year review cycle of USPSTF.
And correct me if I'm wrong, just to make sure I'm not getting too elementary on this, but the USPSTF that you mentioned, what they do is they go through and give recommendations, and then insurance companies, particularly CMS, Medicare, Medicaid, base their reimbursement off of those recommendations. So it could be FDA approved, it could be out there available, but if USPSTF hasn't recommended it, then insurance companies may or may not pay for it at that point. And that could be a barrier, correct?
Especially on the private payer side, they grade the test based on the clinical benefit that they see, and effectively, the paying out of the pocket for this routine cancer screening would go away, and private payers need to cover that test with no longer this financial kind of burden on the patients. And those kind of coverages of the commercial and private payers are going to wait in large extent till the USPSTF grade the test and render their recommendation. But we believe if just the level of funding for USPSTF is get addressed, it's set of voluntary people who are really mission driven and they want to do the right thing for this space. It's just they are not resourced to really evaluate these advancements in cancer screening with proper frequency.
And Anjee, without that payment, without CMS stepping in, without private insurances stepping in, then it's going to be much harder for people to get these tests, which means that it could be the best test in the world, but it might not be used to its full utility.
For sure. From an adoption standpoint, if it's not covered by insurance, it's really quite hard for patients to receive it. And usually what ends up happening is the physicians aren't recommending it if it's not covered. And then in addition to that, from a public health standpoint, the CDC has a colorectal cancer screening program, which is in over 25 states. It cannot adopt a new screening modality in that program, which is it's mostly focused on reaching the medically underserved, unless it's approved by the Preventive Task Force. If the ACS governing body of guidelines changes their guidelines and the US Preventive Task Force does not change their guidelines, it becomes a conundrum for patients because they can really get stuck in these policy changes or lack of policy change, because then insurance groups can then decide, well, we'll cover it in this state because the state covers, recommends the ACS guidelines. And we'll recommend this in this state because it is pointing to the Preventive Task Force guidelines. And so this confusion adds to the challenges we have in colorectal cancer. So not only do I need to know what age I need to be screened, but then once I need to be screened, how should I be screened? And will it get paid? And all these kind of points of confusions and variables cause all the more challenges to get that compliance rate that Dr. Talasaz had mentioned. We're only at 68%. We want to get to 80%, and we need to make it as easy and simple as possible for people.
You know, and it's interesting because I think the pandemic has taught us a lot of things. One of them is that, you know, communication is the key to getting people to do these things, to be compliant in what are the healthcare measures that are out there. And what you're saying, Ed, is that the confusion here could still be out there for these screening tests. And for either one of you to answer this, and without that confusion being broken through, that the compliance rates might not go that much higher, even though we have the tools, they might not be as high as we'd like them to be.
Yeah, exactly. When you think that, you know, typically actually these kind of screening tests, they are, you know, from FDA approval, they sometimes need to wait 3 to 4 to 5 years really to see some of these guideline changes, when then in terms of rate of adoption, it's going to be impacted. And we are talking about, like, you know, in matter of like 5 to 8 years, maybe 500,000 lives that could have been impacted in the United States, that basically it's not going to see the benefit potentially till really the guidelines get updated. That's why we are putting effort to increase the awareness, and really our goal is to support USPSTF so they can get more adequately funded, so they can really review innovative technologies with more reasonable frequency for the patient's sake benefit.
And forgive me if I'm too naive and too sci-fi on this kind of thing, but when you mentioned the USPSTF meeting every 8 years to make these decisions, in the 70s, that might have been okay because of the technology and how rapidly advanced decades ago. But now technology is advancing. I mean, we had a vaccine in 10 months that none of us knew would happen. These liquid biopsy tests are coming out. I mean, these things are going to continue to advance. Yet if USPSTF is only meeting every 8 years, that's going to put a big handcuff on those things. Am I right?
Yeah, exactly. So they meet actually a few times, but, you know, based on the resources and the schedule they have, they cannot have higher frequency in changing their guidelines, you know, beyond every 8 years. So, and their spectrum of influence is pretty large. You know, as I mentioned, it's not just cancer screening they need to be worried about. It's kind of, you know, preventive measures and, you know, a bunch of other stuff that they have in their charter. And even with this broad charter, they are not really adequately funded to really be able to evaluate all these life-saving initiatives and technologies adequately.
Let me go ahead and switch to some questions because we're getting quite a few questions here. I just want to make sure we get to audience's questions. So here's the first one. Given the different modalities of screening, colonoscopy, liquid biopsy, stool-based, what are the rates of false positive, false negative for each method? And how do you present that to patients? So, AmirAli, let me ask you about the false negative, false positive, and then I'll talk to Anjee about how you talk to patients about this.
Yeah, so we presented actually a bunch of data, you know, using our technology. We have to see what we are going to see in our pivotal study, which is called Eclipse, that we are just about to finish the enrollment. And, you know, in a few months, we are going to have that readout. But what we are targeting is really having specificities of over 90% and then very high sensitivity of at least detecting 85 to 90% of early stage colon cancer cases. And this 90-95% specificity is pretty good because there is a follow-on colonoscopy that actually patient can go through, which not only can confirm the finding of blood, it could act as intervention too. If patient has a polyp or a small tumor during colonoscopy, some kind of intervention can happen. And the patient experience would be just a simple blood test is going to get drawn. And the report that's going to be shared with physician and patient is, have we found any signal in blood that basically gives us indication that patient may have colon cancer or advanced adenomas, which are, you know, non-cancerous but early stage tumor that patient may have. And then they can go through colonoscopy to confirm it and do the right intervention.
And with the colonoscopies, most of us, I think, would agree that 10 years, even though that's the current recommendation, when it comes up on you, you're like, wow, that didn't take too long. With the liquid biopsy, if you had to get that every year, that would not be that big of an inconvenience.
We think probably actually the interval of testing would be every 3 years, similar to other non-invasive stool-based testing, but it's very convenient for the patient. And, when you look at actually the cancer development in colorectal space, testing every 3 years gives you multiple shot at the goal to actually detect that early stage CRC. But reality, if you can do it every year, even the sensitivity could become higher, but every 3 years probably is the right sweet spot for this kind of non-invasive blood-based colon cancer screening tests.
And Angie, answering the second part of that question, which is how do you present to the patients all these different modalities of screening they have and help them make a decision?
Well, I think it's a great thing that we have multiple options for patients, because I think that with patients trying to figure out what's right for them, that shared decision-making conversation is really important. Physicians don't have a lot of time with their patients, but being able to say, hey, this year, I know that you're not able to have a colonoscopy maybe, but you have other options, I think is really important. I think it's, when we've talked to patients and we've surveyed patients, it's really laying out that they have options. It doesn't mean that they're wed to that option. It's whatever test you can do and complete is very, very important. But to the interval part, one of the challenges we have with the non-invasive screening tests, when they're annual, they're only effective if you comply annually. So when you look at those numbers, you really have to think, like, if you're skipping years here and there, that may not be an effective option for you. So you really need to think through, like, can I comply with every 3 years? And if you can comply with every 3 years, that is a great test for you. But if you're not able to comply and you're willing to commit to doing a colonoscopy and you're a low, you are a higher risk individual, you might have family history, you might have symptoms, you really need to know how to make those choices. So I think that it's a great time for colorectal cancer in that we have a screening test. This is a preventable cancer. There aren't a lot of cancers you can truly prevent. And with more options like this, we can catch cancer early. And that's like the great hope that we have, is the earlier you can catch colorectal cancer, the more curable it is. Not all cancers can say that.
And Angie, there might not be an answer to this question, but this is something that I've definitely found out throughout the midst of the pandemic, is it's easy to say, go see your doctor and have this discussion with your doctor. Not everybody has a doctor. And not everybody has a doctor that they can sit down and discuss this with them, like you mentioned, time constraints. So what should a patient do if they don't have a doctor, they don't have somebody who can talk to them about this?
Well, I think that, unfortunately, what we're seeing is a lot of patients going into the ER, and that's what we don't want them to see, or we don't want to see happen. But, we really encourage patients to find a doctor. I mean, you really need to have a primary care physician or some healthcare provider that you can speak to about screening. I think this discussion about what is the best screening option is it's a discussion you should have with a healthcare provider.
Great. And here's another question. Let me get to this one. Do you anticipate any policy changes to recommended colon cancer screens for high-risk younger people, or just for younger people in general, especially as we hear more about how colon cancer is impacting younger people more and more? And do you think that the changing guidelines for preventative screening reduces patient confidence in screening overall? And so, AmirAli, let me ask you that first part. Do you think that we should go ahead and have the policy changes for general populations for younger people, or just younger people at higher risk? Or is 45 enough because it just dropped to 45 for colon cancer screening?
Yeah. So guidelines actually just recently changed from 50 to 45. And, some of the actually consideration that goes into this age group is, the net population health benefit versus the health economic argument sometimes in terms of who should we screen, who we should not screen. Now, the reality is when you look at the rate of CRC, colon cancer in younger population, just based on what's happening with the younger generation, the lifestyle, and I think the reality is the numbers are showing us the CRC prevalence is increasing in younger individuals. And I think, in fact, CRC is going to become, or it is already, a leading cause of cancer-related death in younger patients. Like when you look at patients below age of 45, or patients like 20 to 49, the leading cause of cancer-related death in them is in fact colon cancer. And as a result, I think some of these guideline settings, we should look at them as living guidelines and continually monitor actually the prevalence of these diseases and continue to reevaluate that is the benefit at the population level telling us that we have to continue to reduce the screening age, even from 45 to below 45. And obviously more frequent observation and conversation around these guideline setting is going to have life-saving impacts on in younger individuals.
In the second part of that question, Anjee, ask about, do you think the changing guidelines for preventative screening reduces patient confidence in screening overall? Or does it actually increase their, and one of the things I found out in the pandemic is, if the science is explained to people have a better understanding and more confidence. And I think what they're asking is, these screening guidelines are being changed. Does that reduce people's confidence? Does that increase people's confidence? How does it affect
I don't think it reduces people's confidence. I think that candidly, I just think that colorectal cancer needs to be a more well-known cancer that you need to be screened for. But dropping it to 45 expands the patient population from 20 million to over 40 million people who are eligible to be screened, who should be screened. So when we start talking about innovations like the blood test, like Guardant coming out with a new innovation, I think we do need to be excited about the innovations and to be clear about the science and that it's safe, if and when it is safe. And so I think that that's a really important piece, is that what we can't do is tell a scientific story that would cause mistrust of these tests that are coming out. I think it's really important that we explain it accurately and understand how these tools are to be used. But going back to the guidelines, the one thing about the preventive task force guidelines and early age onset is the preventive task force guidelines are for asymptomatic, completely clear patients. The studies that they review are not studies of early age onset symptomatic high risk population. So it's important that we start thinking about a wider strategy for the colorectal cancer community, that we are not just focused on the asymptomatic population, but that we have a different strategy for those young onset patients who may have a family history, may have Lynch and have never been tested, may have signs and symptoms, that there needs to be a way beyond just saying a diagnostic screen or a screen that you're completely asymptomatic. I would hope that, my pie in the sky dream is that the blood tests get approved for any age so that, your blood is your blood, right? And that's not a scientific statement. But that if a doctor needs that tool because they have a young onset patient and they want to pre-screen that patient before they move forward with an additional diagnostic test, that they could, because even for a young onset patient, you just think about, you think you're invincible at 20. You may not take the time to go get a colonoscopy, but maybe if you were able to provide an option to get a blood test and say, hey, get the blood test. Let's figure out if this is really serious. That would be amazing. So, as these technologies advance, my kind of dream is that we could help all patients.
That'd be fantastic. And speaking of more patients being helped, building up on the equity conversation here, how can we make sure clinical trials for these new promising tests are representative of the patient population?
That's actually a very good point. In fact, in our study, we wanted to go actually to the sites that even the prevalence of colon cancer in screenings actually are higher, so we can do the study faster. So in fact, in our study, we have a very good distribution of underserved patient population and people who have better access to the health system. And as a result, our patient population is really well representative. But this is a broad kind of a question across the board, how to bring all kind of clinical trial to underserved population when the access to healthcare for many of them are kind of limited. And I'm happy with some of the progress I'm even seeing on the biotech and pharmaceutical kind of trial, that they are really trying to bring a bunch of these therapeutic intervention, medical device kind of innovations deep into the community and deep to the patients who really can benefit from it versus just relying on academic centers or major community centers that really are not representing many underserved patient populations. But still, the gap is meaningful, and we have to continue to push this across the board to make sure those individuals are well represented in spectrum of clinical trials that are happening.
And for either one of you, is that representation important for the outcomes of the test to make sure that there aren't issues or differences between different ethnicities or races or groups of people, or is it more the confidence of people in the outcomes of the test and their ability to start taking the test once they're ready, or both?
I think both. I think it's important that all populations are represented in the clinical trials. I commend the industry partners that have research advocates that are a part of the design and execution of clinical trials, as well as being able to report the outcomes of these clinical trials with authenticity to say that your community was represented and that this is not a clinical trial that's going to just guess what's going to happen, but they've really truly thought through how to recruit and represent a wide variety of populations.
Let's see if we can get through. No, go ahead.
And we applaud actually a bunch of progress that has made by agency, FDA, and CMS to really they're demanding some of these criteria to be implemented in different kind of clinical trials. Having said that, I think still there is material room for progress, and we also have work to do to increase the overall trust in our healthcare and health services, especially by underserved patient population. And I think still, I believe the future would be bright for them, but we have work in front of us.
I want to see if we can get a couple more questions squeezed in here before we have to unfortunately go, but one of them is about early diagnosis for ovarian or pancreatic cancer. Will these blood-based screenings being applied to those as well?
So the blood test actually we are working on, the colon cancer is our lead indication, but not the only indication. In fact, we recently mentioned that we are expanding the indication to colon cancer and lung. We are starting our study in lung cancer screening space very soon. There are few cancer types that we are interested in, and our general philosophy is we want to go after cancer screening where we can save lives, and not just go screen for cancer that the only thing that we do is generating anxiety and potentially financial toxicity. And we harm the population by offering those tests. But there are several of cancer types that are recommended by guidelines that screening would add value. And we believe there are some other cancer types that based on interventions out there, a right screening test with right intervention would really offer positive population health benefit. Some of the cancers you mentioned, like ovarian cancer, unfortunately, there's been a report across 200,000 cases that although you can detect maybe ovarian cancer, long-term studies showed the survival has not improved really by early detection. I think it's just a matter of time. And prostate, that could take an hour of conversation of prostate cancer screening.
Excellent. Last question, just real briefly for either one of you. When we look at the genetic tests or genetic testing sites that are out there, 23andMe being the one that the person mentions, but the NIH is doing their own as well. How do you leverage that going forward for these different types of screening tests in cancer prevention? So
I think that's a complicated question. For us as a patient advocacy group, sometimes it's great and sometimes it's challenging as well, because with the 23andMe tests and some other tests that are out there, it's really understanding what type of information you're receiving from those tests. And I don't know that I think it helps us have the conversation, but I just want to re-encourage everyone that even with those tests, you really should be talking to a healthcare provider about your specific genetic risks for cancer in general and what you should be doing to prevent cancer. For colorectal cancer specifically, understanding your genetic mutations is a much broader conversation that patients should be having. So I think it's a conversation starter.
And AmirAli, that information that's out there, the genetic sequences that are out there on people, is that something that can be leveraged moving forward?
So those genetic predisposition, which is an evolving field, is basically help with risk management. You know, what is your risk for developing a specific disease, including cancer? And, you know, what are you going to do with that information? What we are talking about is really a test that can detect, are you cancer-free or you potentially have cancer, right? So, you know, your average risk or high risk, you know, it's still, you can benefit from that screening. So genetic tests are very good to know what is the risk. And some people like to know that information. Some people prefer not to even know that information. I think we see health benefit if people know which risk category they are in, but then follow through of what the next step is, appropriate next step is based on the risk category that you're in.
Mm-hmm.
And the example I often give people, and tell me if I'm wrong, is with heart attacks. You know, if you have high cholesterol, if you have a family history, that puts you at a higher risk for a heart attack, but doesn't necessarily mean you're going to have one. Whereas if you have chest pain and ERC EKG changes, you are now having a heart attack. And so that's a big difference. One is a risk of a heart attack, versus the other one is here's what you're having right now. And it seems like
Exactly
the same
right.
thing here. The genetic tests tell you you might be at a higher risk for this, but the blood tests you're talking about are saying, hey, we are seeing evidence here that you actually have something happening.
Correct. That's a good comparison.
And it's
Thank you guys very
important
much. Go ahead.
I was just saying that even if that test comes back and it says you're not at a higher risk, you still have to be screened. So that's sort of the message that we just want to make sure that people still get screened.
That's a fantastic point. And the same thing, using the heart attack analogy, just because you have normal cholesterol, no family history, that doesn't mean you're not going to have a heart attack. You still need to be careful. And so same thing here. But I appreciate you guys both being here with us and taking the time. Like I said, we could talk about 4 hours and we didn't even get into half the stuff we wanted to talk about. But thank you, AmirAli. Thank you, Anjee, so much for being here with us and for helping us out and understand this and hopefully pushing forward a little bit more the future of cancer detection and cancer prevention, because one thing the pandemic has taught us is that prevention is the key to keeping everybody healthy here. And so I want to thank you guys as the panelists for being here. Thank you very much. I want to thank Aspen Ideas Health for sponsoring this and giving us the platform to talk about this. And for everybody that listened here, please stay as healthy and as happy as you can. And like I said, let's look out for ourselves, our families, our loved ones, and our communities, especially right now, and get through this pandemic as soon as possible. Thank you guys very much.
Thank you.
Thank you.